the first fill. My name is Katie Meyer, and I serve as the Senior Director of Content Creation here at APHA. This month, we are reviewing recent updates related to medication safety and are happy to provide you with valuable medication safety CPE for listening. Be sure to head to the Learning Library to ensure you don't miss out on your CPE credit. In this episode, I'm going to discuss a recent retrospective cohort study published in JAMA that compared the risk of serious bleeding with combination therapy metoprolol or diltiazem in patients who had atrial fibrillation and were new users of DOACs, apixaban, or rivaroxaban. I hate to admit this, but I'm of the age that back in my day, all we had was warfarin. When the DOACs first came out, I was nervous. I didn't have that objective INR range that ensured my patients were effectively anticoagulated with the least possible likelihood of adverse events. As I started to have more experience and evidence continued to evolve about DOAC superiority, I became more confident in recommending and using them. However, still to this day, I'm very cautious when it comes to drug-drug interactions. Apixaban and rivaroxaban are both weak affinity substrates of the cytochrome P450 enzyme 3A4. If a medication has stronger affinity for the CYP3A4 enzyme site or inhibits the site, co-administration will lead to reduced metabolism of apixaban and rivaroxaban, increased concentrations, and greater potential for adverse drug events such as bleeding events. Additionally, apixaban and rivaroxaban are both substrates of the P-glycoprotein, or PGP transporter, a multi-drug transporter that uses ATP to actively transport substrates out of the cell against their concentration gradients to promote elimination. When combined with medications that also inhibit PGP efflux, this further leads to potential for reduced elimination, increased concentrations of the substrate, and adverse events. Diltiazem has strong affinity for CYP3A4 and has also been identified as an inhibitor of PGP. While the interaction between diltiazem and DOACs, apixaban, and rivaroxaban has been studied over time, up until now, we really lack strong evidence that co-administration should be avoided or dose reduction should occur. It's certainly a combination that we see often in practice, though, in our patients with atrial fibrillation. This brings me to the recent JAMA study, a retrospective cohort study including Medicare beneficiaries aged 65 years or older with atrial fibrillation who initiated apixaban or rivaroxaban in combination with diltiazem or metoprolol over an 8-year period that were followed for a full year. The primary outcome was a composite bleeding-related hospitalization and death with recent evidence of bleeding. 204,155 Medicare beneficiaries, 53,275 of which received diltiazem, and 150,880 of which received metoprolol, were included in the analysis. Patients had a mean age of 76.9. Patients receiving diltiazem had a statistically significant increased risk of combined composite outcomes, as well as an increased risk of each of the components, both bleeding-related hospitalization and death, with recent evidence of bleeding compared to those taking metoprolol. Researchers also found a higher risk correlation with diltiazem doses exceeding 120 milligrams per day compared to lower doses of diltiazem. The major takeaway when reviewing this study for me was that we need to be thinking carefully about the use of this combination in our patients with atrial fibrillation, particularly older adults, and weigh the risk versus benefits of its use. Apixaban's product label suggests a dose reduction or avoidance of concomitant use with strong dual inhibitors of CYP3A4 and PGP. Rivaroxaban's label recommends that the combination be avoided. When you see a patient taking this combination, it's certainly worth a call to the provider to make them aware of the interaction, as a safer alternative such as metoprolol could be considered if clinically appropriate. Well, that's all I have for today. Remember, this month, by logging into APHA's Learning Library and completing a quick assessment and survey, you'll earn a half hour of medication safety CE. I hope this helps you as you're working through your licensure requirements. Take care.